Hello, this is Dr. Todd Cielo with DXD Software. Thanks a lot for taking time out of your day for this 30-minute ligament laxity webinar. We're going to be going over 3 objectives today. First, I'm going to be going over the clinical medical aspect of ligament laxity and how this pertains to your practice. Secondly, I'm going to be going over the legal aspect of ligament laxity, how this can help you with documentation. And thirdly, I'm going to show you how DXD software marries the medical and the legal aspect together in a 13 to 15 page diagnostic report. These are the topics that we're going to be going over today. Ligament laxity, big buzzword that's been going around for at least 10 years. There's 2 things you need to know about ligament laxity. 2 definitions. One is translation, which is the forward-backward movement of a bone. The other is angular motion, which is the flexion or extension or the posterior widening or the anterior widening of an intervertebral disc space. George's line is the posterior aspect of the vertebral bodies. It's been around for almost 100 years, and that's what pertains to ligament laxity. The AMA guidelines, 4th, 5th, and 6th edition. There's subtle differences in all 3 of them. I'm going to be going over DRE differentiators to help you out from a subjective standpoint with the correlation of the objective findings, as well as where this ligament laxity helps you from a DRE category standpoint. CRMA, Computed Radiographic Mensuration Analysis. This is what the insurance companies recognize ligament laxity analysis as computed radiographic mensuration analysis. Big fancy word that simply means everything is being measured from a computer standpoint. DXD reporting software. I'm going to go over how my DXD software marries the medical and the legal aspect together, as well as showing you demonstrative images to show how anatomical alterations are set in the human body, as well as where the Sharpie fibers and the annular fibers correlate with disc lesions from a future standpoint. As doctors, we face a handful of challenges, but the biggest one is documentation. We need to be able to verify connective tissue injuries. Connective tissue is simply that. It's connecting one bone to another. Hence, that's what ligaments do. Subluxations. A lot of DCs, MDs, and DOs use this word as far as the diagnosis. So they locate them for whatever technique that they use or diagnostic imaging that they use, but very few people define it, and I don't see a lot of people quantifying it. And I'm going to show you how the DXD software does all 3. Objectify permanent injury. This is where we start utilizing the AMA guidelines, radiology books, etc. in order to formulate forensic evidence. Now it's no longer opinion-based. And lastly, learned treatises. Learned treatises is something that the legal group and all the counselors, court, etc. rely on. What we need to be able to understand is how these attorneys use these and how we can objectify our findings in our office to help them quantify injuries. The foundation of locating subluxations, or the foundation of locating ligament laxity, is George's line. George's line's been around since 1919. It's the posterior aspect of the vertebral bodies. Hence the red line. Nice curve right there. So the left of that line is the anterior part. On the line is the posterior aspect of the vertebral bodies. And if there's a break in there, break in George's line, there's 4 reasons. Not basic reasons, 4 very specific reasons. 1 is fracture, 2 is dislocation, 3 is degenerative changes, and 4 is ligament laxity. If it's the first 2, all we need to do is stabilize it. If it's the other 2, we need to be able to document it and, more importantly, differentiate it. And that's where the DXD software comes into play. So the connective tissue injuries. Ligament laxity. The code is 728.4. 728.4 is a diagnostic code. And that code has a few benefits. One is you get to treat the patient longer. Two, it's a value driver. So these severity points that are added up throughout the case creates value drivers. And this is one of the biggest, most undocumented value driver that I've seen. And it's an objective finding. You can't fake the movement of an x-ray, just like you can't fake the outcome of an MRI. We can fake symptomatology all day long. So where do we find it? We find it on linear views, sagittal views. That's what the AMA guidelines recognize as linear sagittal views. ADP open mouth, lateral bending, shows a slippage of atlas over C2. MRI findings, most of them are static, but you can still find those anterior or posterior subluxations, which gives you reasons for medical necessity. The oblique views as well, because now when you look up, now you have that foraminal encroachment, because that retrolithosis will make that foramen stenose. So now let's define those subluxations. We have 7 different types of subluxations according to Yoakum and Rowe. We have an anterior lithesis, which is the forward movement of a bone. We have a retrolithesis, which is the backward movement of a bone. We have a flexion, which is a posterior widening of the intervertebral space. And we have extension, which is an anterior widening of the intervertebral space. Also, we have lateral flexion, rotation, and lateral listhesis. Lateral listhesis comes into play with the ADP open mouth, and I'll get to that later in this segment, showing you how to quantify that and how to utilize that for impairment ratings. From a DC standpoint, whenever we're utilizing radiology, we utilize it 3 different ways. We use technique, which is basically positioning, analysis, which is lines of mensuration, which we were taught in school, and interpretation. That's where we utilize the AMA guides, Yoakum and Rowe, to utilize and formulate this forensic evidence, so it's no longer opinion-based. So here's a typical view we see in our offices all day long. Kyphosis, a kyphotic neck. You can see between C2 and C3, nice parallel disc space. We see between C3 and C4, that wedging. That posterior wedging right there. Between C4 and C5, posterior wedging. C5 and C6, pretty parallel. C6 and C7, we have anterior wedging. So this is just a static view. So if we go into flexion and extension, we're going to make this look uglier, make this look uglier, and possibly this look uglier in extension, because we want to promote stress. That's what the AMA guidelines wants, are stress views. So the 6th edition AMA guidelines, flexion extension x-rays, provide useful information of AOMSI. AOMSI is alteration of motion segment integrity. Fancy words for ligament laxity. But you can see that they're utilizing flexion extension. 5th edition AMA guides. Dominant motions at cervical and lumbar spine, where most clinical pathology occurs, are flexion extension. Same stuff. Different verbiage, same stuff. Then we start using what are called DRE differentiators, diagnosis-related estimate differentiators. And we use this for several reasons. One, we want to be able to categorize a patient in a DRE category. So what I like using are the 7 common DRE differentiators that are agreed upon with the 4th, 5th, and 6th. 4 of which are subjective, 3 of which are objective. The 4 that are subjective are muscle guarding, atrophy, loss of reflexes, loss of bowel control. The 3 that are objective is electrodiagnostic testing, a cystometrogram, which is basically a bladder study, and then lastly, AOMSI, which is ligament laxity. They agree on those 3 that are objective. So this is where it all began in the mid-70s, 1975. White and Panjabi did some cadaver studies. They did 8 of them. They found out, let's just talk about the cervicals, make it easy. They found out that the cervicals at 3.5 millimeters of translation, which is that forward-backward motion, and 11 degrees of angular motion, they found out that was clinically significant from an anatomical standpoint. They said it was inconclusive, but they said it was significant. In 1978, they created their first edition of Clinical Biomechanics of the Spine, and they confirmed it, that 3.5 and 11 degrees were significant. Any questions thus far? So, now let's quantify it. Key about deposition, mediation, and especially court for the jury comprehension is demonstrative aids. And the easiest one that I've seen for 3.5 millimeters are quarters. A height of a quarter is 1.75 millimeters. 2 quarters on top of each other, exactly 3.5 millimeters. Doesn't get any easier than that for someone to comprehend the significance of that translation, which is flexion and extension combined. So what I like to do in court or deposition is make them aware that 3.5 millimeters is a big distance for a bone to travel, causing foraminal encroachment, nerve root impingement, any type of thecal sac impingement, afferent, efferent problems, and you create that and correlate that with their symptomatology. Any questions? Here's a typical view from a DXD software from one of the pages of extension. The patient is looking up. So we can just look right here at C2, C3. George's line looks pretty good. At C3, C4, you can see that retrolithiasis. At C4, C5, you can see that retrolithiasis. C5, C6, a very small retrolithiasis. And C6, C7, very good. So one of the pages with all the measurements, you can actually see that abnormal and radial segments are in red. And anything over 3.5 millimeters that you see at C3, C4, and C4, C5 is over that 3.5 millimeter. So this patient would be rateable at 25% DRE category number 4. Here are some copyrighted images I had made. On the left-hand side, the retrolithiasis is that backward movement of a bone. And where the red arrow is pointing to is that ALL, or that anterior longitudinal ligament, creating that retrolithiasis, which will cause foraminal encroachment. We have the ALL on the front here as well, the widening of the anterior disc space. So when they extend their neck, it might not be translating backwards, but it is wedging. And that's where that 11 degrees comes into play. Again, this is in the 5th edition. You can check out pages 378, 379. The DRE category is on pages 392. Here's a typical stress view that we see in our offices all the time. You can see at C2, C3, there's forward movement. C3, C4, C4, C5, C5, C6, and C6, C7 is almost perfect. So this would be a typical flexion view. In all DXD reports, 3 views are required. A flexion, which is looking down, extension, which is looking up, and a neutral, because we need a reference point. AMA guidelines likes those linear flexion extension views. The PLL, which is the posterior longitudinal ligament, which is in the back of the vertebral bodies, actually along George's line. You can see on the left here the widening of the posterior disc space, which is creating that wedging where that angular motion is recorded in degrees. Anterior lithesis, which is that forward movement of the bone, and that's where that 3.5 millimeters is measured. The Adipiopa mouth lateral bending, here's a good view You can actually see on the left here the lateral mass overhanging over C2. That's the discrepancy that we want to measure. Here it is on the right, same patient. So right here, DXD measures A to P open mouth, lateral bending left and right. So after we plot the points, then we want to get this measurement. When we get the measurement, now we have 6.19 millimeters on the left, 7.04 millimeters on the right. So the accuracy is up to 0.01 millimeters, 100th of a degree or 100th of a millimeter. White and Panjabi state that if the total of left and right lateral bending is greater than 7 millimeters, occiput C1, C2 is clinically unstable. I would label this as 6% impairment and add that to any other type of impairment that I have. So if this patient was at 25%, I'd add 6% to the 25%, and that would be 30. You can see on the page 604 of the AMA guidelines where you add 25 and 6, and that equals 30% impairment. Here's a great one-liner to memorize. It's on page 379 of the AMA guidelines, 5th edition. To be diagnostic value, clinical signs and symptoms must agree with imaging findings. In other words, an imaging test is useful to confirm diagnosis, but an imaging result alone is insufficient to qualify for a DRE category. This is very important. A lot of doctors just rely on MRI findings, and a savvy defensive counsel should know this. And if they know this, you better have something more than just symptoms and an imaging. You have to have other correlations with this. That's why I like the objectivity of ligament laxity. And this is what the AMA guideline says about disc lesions. 30% of us by the age of 40 have a disc herniation without radiculopathy. Aging changes begin in 40% of adults after the age of 35. And almost all of us have some type of desiccation, dehydration, disc lesion going on by the age of 50. These are powerful statements. That's why you need something more than just MRI. I'm not saying the DXD eliminates the MRI. I'm saying utilize this in correlation with signs, symptoms, correlation with all the subjectivity from their consult, as well as how this interferes with duties under duress, loss of enjoyment, hobbies, etc. Again, this is at the bottom of the page of 383 on the bottom right-hand side. Abnormalities on imaging studies does not necessarily mean the individual has an impairment due to an injury. That's right after these quotes on the bottom of the right-hand side of that page. So, understand this and embrace it. Don't try to fight it. Just embrace that we're all going to have something, whether it's chronic or acute. This is what I utilize in my practice. I always still use MRI findings. It's the gold standard, in my opinion, because it shows more than just disc lesions. It shows space-occupying lesions of any kind. I still like to take linear stress views because that's what the AMA guidelines likes. So your typical Davis series should have these in there. Then I digitize the x-rays with my DXD software to formulate measurements, quantification, objectivity, and more importantly, an impairment rating. Now your opinion is out the door. And then if needed, we get an overread by radiologist. What I like doing with my attorneys, doctors, is I get second opinion patients where MDs and or DOs or other DCs, along with case managers and attorneys, send me patients, and then I just do steps 2 and 3 with them. I fill in any holes if any MRIs are missing, but typically I just perform steps 2 and 3. Here is a typical digitizing of x-rays, CRMA, that I perform in my office. It's about 3.5 minutes. This is Dr. Todd Cielo with DXD software. First, we're going to fill out patient demographics, last name, first name, date of birth, male, female, date of radiographs, date of analysis, date of accident, referring doctor's name, spinal regions involved, cervical, thoracic, or lumbar, APOP lateral bending as well. AMA guidelines, 4th, 5th, or 6th edition can be selected. Medical necessity, you're checking off indications, signs, and symptoms, all reasons for the next academic diagnostic step. Save that, go to the digitizing screen. Now we're going to select 3 views. First we're going to select neutral, line that up, flip the x-ray, save the view. Next, we're going to get a flexion view. AMA guidelines likes linear view, sagittal views. There's your flexion. Next, we're going to get extension. Save the view. And now we're going to digitize, plotting of the points. You plot the 4 ends of the cortices and the spinal lamina line. What we're evaluating here is George's line. George's line is the posterior aspect of the vertebral bodies. And if there's a break in George's line, there's only 4 reasons for the break: a fracture, dislocation, degenerative changes, or ligament laxity. Ligament laxity is the reason why we're doing what is called CRMA, Computed Radiographic Insertion Analysis. Here's the neutral view. So in a few minutes, we've entered the patient's data, selected 3 views, plotted 3 views, and upon the last view, DXD software has generated the report. And the report you have in front of you is the sample copy of this report. Thanks for your time, and look forward to serving you. Please call if you have any questions or visit our website, dxdxray.com. Thank you. Any questions thus far? So DXD software is available for lease. $450 a month allows you to generate 20 DXD reports. The code that I utilize is 76499-22, bill by report. It's a biomechanical radiographical report. So when you send this out to the insurance company, please make sure that you send out the report with it, so it's a tangible item that they can thumb through. The first 5 pages is all medical necessity. That's what that demographics page has, and I bill out $450 a report. So the return on investment is basically 20 to 1. If you do not want to lease the software, I do have a CRMA service. Just give me a call or visit the website, and you just fill out the information and send us the x-rays, and we'll be happy to furnish you a report, and we'll bill the attorney or the insurance company. If there's any attorneys that are on this call as well, you can just send us the flexion extension neutral x-rays, and please give me a call. I'll be happy to send you out more information. Here are some sample cases that I've been involved in over the last 2.5, 3 years. Obviously initial offers are usually low, and the main aspect of DXD is comprehension of anatomical changes. And that's where you have to relate ligament laxity to future regressive, painful, permanent injury. And when there's instability of a ligament, all adjacent structures are going to be degenerative in nature. And that's what we have to show. I really appreciate everybody's time today. My cell number's at the bottom, as well as the website. You can contact me at Dr. Todd, TODD, at DXDXray.com, or give me a call on my cell anytime. Thanks for your time, everybody.